All right. Well, thank you everyone for joining us. We're really excited to have you here. We are doing a panel about domestic violence and public health, what that looks like here in our community, what those costs can be. So we'll go ahead and get started. If you have any questions at any point, just put them in the chat. And we will get those answered for you. We want to have this conversation not so much about saying like that this costs a lot. It's not about the money specifically. It's just more about trying to show like how this affects the community as a whole. And so we're going to talk a bit about cost of prevention versus the cost of crisis intervention. So we have some great panelists here today, and I would love it. Each of you can take a moment to introduce yourselves. I would love to, if you could introduce yourselves, introduce your agencies, let us know what you do at your agencies and kind of how you got into that work. And then maybe talk about what kind of work you guys do that specifically might work with domestic violence. Susie, if you would like to go first.
Of course. Thank you, Adrianne. Thank you to the Willow for hosting this event. My name is Susie Green. I am with the Community Children's Center, and I am an outreach coordinator for our Family Resource Center. So what all those words mean is that I'm here for family support. My background is in social work, and my social work has always been in early childhood or in family support capacity in some way. So with the CCC, we have several different things that we do, but my role is really focusing on family support with families in Douglas County that have kids 0 to 5. So thinking about the intersection with domestic violence for our agency, it's almost always when there are children involved, and helping caregivers connect to the right agency, talk through some of the shame and courage that comes with big decisions that are being made around children and caregiving during this time, is really a place that we can step in and provide a little bit of support. So thank you for having me.
Yeah, thank you so much for being here. Megan, do you want to go?
Hi, everyone. My name is Megan Luttrell. I work at LMH Health. Currently, I am employed by LMH Health. However, I am going to be working at the Treatment and Recovery Center when it does open as a behavioral health specialist. And I got into this field a number of years ago, around 2009, 2010. I started working at a substance abuse treatment center in Topeka, Kansas, and I absolutely loved that work. I transitioned to the anti-violence movement when I started working at the Willow Domestic Violence Center in 2018 as a human trafficking program coordinator. And that was something that became super passionate to me. I've seen a lot of my friends, coworkers, loved ones that I know experience domestic violence or human trafficking. And so it's a cause that is very near and dear to my heart. Right now, I am just focusing on taking care of patients that come into the Gold Unit in the ED at LMH. And really what that looks like is when they come in, I help with the vitals. I collaborate with the social workers, the nurses, really to provide a supportive care to that patient that is absolutely terrified coming into emergency room, because it is not an ideal situation for mental health patients to come into the ED, but that is where we're at currently. And so, as we talk about this more and more, you see a lot of the people that come through the ED that are patients have had a history of abuse or some traumatic event that has contributed to their crisis. So this is very relevant, and I appreciate you asking me to speak.
Yeah, thank you. Thank you so much for being here. Great. And Emily?
Hey everyone, I'm Emily Ramey, and I am the Intensive Outpatient Program Manager and the Dialectical Behavioral Program Manager over at Burton Ash. So I work with a lot of adults who have difficulty regulating their emotions, often with chronic self-harm behaviors or with chronic suicidality. Lots of folks with personality disorders and things like that. I'm a social worker, and I came to this work I started out in special ed, working with a lot of high school age kids with autism and a lot of kids with mental health concerns going on that were related to chronic abuse and being in the foster care system and things like that. And then from there, I went and worked at Wichita Area Sexual Assault Center for a couple of years, doing advocacy work and crisis work, and kind of started getting really interested in the intersection between mental health and trauma, particularly when it comes to like folks with personality disorders, and figured out that I really enjoy working with that population. And so that's how I kind of ended up over here doing DBT.
All right. Very cool. Thank you so much. So yeah, we've kind of touched on it a little bit, but I would really like to talk about how DV looks in your agency, in your field. Like, what sort of things are you guys seeing? Basically, kind of how does it manifest in the work that you're doing? And anyone can, yeah, sorry. Megan, do you want to go? Looks like you're.
Sure. One thing we do see people, of course, come through in crisis that have experienced domestic violence, human trafficking. One thing that I absolutely have found, especially working in the hospital setting, is that people don't want to disclose. They're not willing to disclose. I don't think necessarily it's a setting to disclose. And so they're in crisis. You know, we've had people come in, especially younger women that have had clothing that is like just a t-shirt and, nothing else. We've seen that a couple of times come through. And so one thing, I know the social workers absolutely do their best to, acknowledge that this might be a component of why they're in crisis. But as we all know, if someone isn't going to, tell us this is the reason I'm in crisis, or this is the reason it contributes to crisis, it can be really hard for us to assist and help them. Another thing, and this might be kind of something we talk about later on, is that when people do come through, finding services for them has been really difficult, especially for people experiencing DV or human trafficking. So I know it can be a frustrating situation for the social workers when they're working really, really hard to find that placement for somebody in that safe zone or that safe place. And so that's something we're seeing a lot of, is just feeling restricted in how we can treat them, and the placement of the individual when they're coming into the ED. And sometimes they're saying, I do want to go somewhere safe. I do want to escape and flee domestic violence or human trafficking, but we just don't have anywhere to send them or place them.
Yeah. If you're calling something, like if you're calling our hotline at the Willow and we are just always full, it can be really hard to get them someplace else. Everyone is always saying, oh, we serve only people in this area. So trying to get them to, even Kansas City or Topeka, there's usually just barrier after barrier. And I know for us at the Willow, our shelter is almost 100% full all the time. It's really tough to call, and it's not regular that like a bed is just available, immediately. And so that can be really, really difficult for sure.
Right.
Thanks, Megan. Susie, do you want to go?
Yeah, of course. Thank you. I think I jumped into this first question a little bit in my introduction. Most of how domestic violence intersects with my work is typically involving the children that are involved in that situation. So for that work, it's really a both and work. We're working both with the caregiver, the survivor in that moment. So we're working in some emergency crisis intervention. And at the same time, we recognize that brain development, our body development, our health is all happening simultaneously, especially in that birth to 5 age group where it happens so fast. It's so substantial. So working with that both and, how do we engage in that parent-child relationship and interaction? How can we have open conversations about how to repair relationship and build trust and security and safety? And recognizing that it's not a quick fix. It's an ongoing, as all relationships are, right? It's an ongoing effort to really raise humans and raise ourselves and unlearn and relearn so many things. So that parent-child relationship is a huge aspect of where it intersects. And then that co-parenting relationship as well, because we might be in a situation where partners are going to separate for all sorts of reasons, and there's not going to be any contact. there's also going to be a lot of situations where there's going to be legal guardianship that's going to continue, and having conversations about how do we navigate that co-parenting relationship, keeping in mind where our child is developmentally, their spiritual growth, their body growth, and how we engage in that again, that safety and repair. Because if we can help their brain foundation build that safety and connection now, that is just going to carry them and support them throughout the rest of their lives. So working in that both and of intervention and prevention at the same time.
Yeah, that's excellent. I really think about, how our brains, 1 to 3 especially, are just like little sponges. And even though we can't remember everything, if something traumatic happens, it still leaves an imprint on us. So I think that is a huge part of prevention work, because we talk about cycles of violence as in, if I'm in a specific relationship and we're in our own cycle of violence. But I also think of cycle of violence as like even a lifelong thing. If I am witnessing abuse or being abused at a very young age, even if I don't necessarily remember it, that imprint can start a cycle of violence that continues throughout my life, whether it's in intimate partner relationships or friendships or whatever. It can really be long lasting. And so, yeah, I think that's great prevention work on trying to, like you said, mend those things, rewire how we think about things that can really help to break those cycles. So that's excellent. Thanks, Susie. Emily?
Yeah, and that is like such a great lead into my area, right? Because we work with a lot of adults who have experienced various kinds of abuse throughout their lives, and have had that experience of their brain being formed by an environment that was abusive and invalidating and really scary. And often that creates a pattern of really extreme emotional reactions in folks where they are kind of, a little bit cut off from their emotions when they're at a low key level, but when they go into those really overwhelming moments is when they become aware of the emotion. And so they tend to not be great at setting limits, as asking for what they need, or even noticing when someone is safe or not. And often folks who have had a history of lots of abuse throughout childhood and adolescence tend to kind of get targeted a little bit for more abuse. It's definitely a factor where they kind of end up in that cycle over and over again. And so from a therapy perspective, we see someone like that coming in and they have a lot of these like really big emotional reactions and really big swings in mood. And we start kind of trying to like treat that part of it and help them communicate better in their relationships. And often, as Megan was saying, like folks are guarded to disclose what's going on in their home and in their relationships when they first start services. Especially, my programs, we often get folks who have been recently hospitalized or recently in the ER or something like that, and we're kind of providing that ongoing care. And so often it's when we are able to really build a trusting therapeutic relationship with folks that we start to get more information about what's going on in their relationships and their history of abuse or current abuse. And so from there, we can start kind of giving some education about, cycles of abuse and patterns of control and things like that. And start doing a little bit of motivational interviewing and help them kind of like figure out what they're wanting, if they're wanting to exit that relationship, and support them through that whole process. And often that means connecting them over with you all at the Willows, whether it be for housing, or I know you also have some really amazing case management services and things that can kind of help people prepare, financially and emotionally and all of those different ways for exiting. We also get folks kind of coming the other way where they've been working with you all or they've exited a situation and they're kind of figuring out how to put pieces together and kind of like go on and break that pattern and that cycle a little bit. So that can be really cool work to do too. So a lot of times we're kind of like helping people manage symptoms of PTSD and symptoms of chronic abuse, so that they have the coping skills needed to actually be able to go into like a more trauma-centered treatment when they're able to kind of keep themselves a little bit safer and things like that. So it comes up in all sorts of different areas, and we help people in lots of different parts of the abuse cycle, whether it's like actively happening or they've exited it or it was many years ago. Yeah, but there's definitely a huge overlap with mental health. and trauma.
Absolutely. Yes, thank you. That's great. I think, yeah, um, honestly, I feel like, yeah, sometimes we do have clients that come in that aren't necessarily fleeing domestic violence or human trafficking in that moment, but those basically those reverberations of that trauma and the things that they're experiencing, even if it's years down the line, those things have had such an effect. It's hard to keep a job. It's hard to um, feel safe going to certain places. It's hard to get my housing because my ex-partner, would wreck every single place we lived, and now no one will, rent to me. All of these different things that can make it really hard to, quote unquote, pick yourself up by the bootstraps, because you're still feeling those effects years later, both emotionally and like in real life on how it's affecting everything. So yes, perfect. Just want to take a quick moment to just, again, if you're on Facebook and you're watching this, if you have any questions at all, please feel free to put those in the comments. We will definitely take a look at those. We can answer any questions that you all have. So just kind of, and again, we've kind of touched on this a little bit, but just wondering kind of how your organizations are managing domestic violence. You guys are not domestic violence organizations, so it makes sense that, you wouldn't specifically be doing that work. But I'm just wondering if you guys, as agencies, overall discuss how you're handling domestic violence, or even if you have policies and that sort of thing in place, what those discussions look like for you guys as a whole. Susie, you want to go?
Of course. Well, I would give a shout out to the Willow's trainings. So if you're in an organization and you're watching this, or if you're an employee and you want to suggest to your supervisor, the Willow has some wonderful educational opportunities that you could reach out, and they could talk you through and help you identify a plan for your agency to work through. So as someone that does home visits, safety is of the utmost importance. So it is definitely something that we talk about quite frequently. Also in connection to how we're navigating our own presence and our own self within those interactions, how we process and repair after we leave certain situations and homes as well, because we're in a relationship just as that family is in a relationship with themselves. So it is very much a reflective practice, keeping safety for ourselves, our home visitors, and the family at the forefront. And we've utilized Adrianne and the Willow for many trainings. And again, I would highly recommend that if that's something that maybe your company doesn't have, or you do, and you just would like someone to come in and give you a refresher and re-talk through some of those points.
Thank you, Susie, especially for the plug. We appreciate it. We do love giving trainings and connecting with others, because again, that's a huge part of the prevention side of things. Is the more that we know, the more that we can, hopefully, avoid a situation like that, but also, being able to kind of help someone see a red flag. I luckily, in my current position, I get to go into the schools and talk with like 8th graders about teen dating violence, 9th graders about human trafficking. And I grew up here in Lawrence, and we did not have anything like that when I was going to school. And so I think it is so great because, some of us come from homes that we have never seen an example of what a healthy relationship looks like. So if you don't know, then, why would anything change, So just being able to have those conversations and those trainings are a big part of our prevention effort, and hopefully are, having a good effect on people. So Emily, you want to go?
Yeah, so we, like Susie, we talk a lot about, staff safety and safety for clients in treatment when we know that there's domestic violence going on or we suspect it. A big way that that's come up in the last few years has been the switch to telehealth, where we've had some situations where we're aware that there's a pretty strong pattern of control happening in a relationship. And then the therapist becomes aware that maybe the partner is just off camera during the therapy sessions and that kind of thing. And so navigating that sort of situation and making sure that people really genuinely have a safe space to access services, and that we're ensuring that, and that we're not putting them in danger as they try to do that. But also, maintaining staff safety when, your face and voice is entering someone's home, even if you're not physically there, especially when that person sees you as a potential threat, as you're teaching their partner how to set limits and things like that. It comes up often when we talk about, appropriateness for different programs. I know the programs that I manage are heavily group therapy based. And so we talk a lot about whether or not people with a history of violence towards others are appropriate to enter those programs, even though they might need some of the skill set to regulate emotions, and making sure that we're not putting somebody who has a history of abuse as a perpetrator in a group with a bunch of people that have experienced it, so that they can get to know all of those folks and potentially target them. So it's kind of that responsibility of making sure that we're keeping people safe and being really intentional about what services we're offering. We also have a really clear policy in our relationship therapy services that we don't provide couples counseling or couples therapy for folks where there is a history or pattern of violence happening in the relationship. And so if that does come up in that setting, we separate the folks and give them individual therapy. We also have an anger management class that often folks are court ordered to when they've perpetrated and things like that, where we can kind of help folks learn some of those skills to prevent further behaviors when that's an issue going on. So lots of different areas. We also have quite a few community support services at Burt Nash now. So we have a pretty expansive housing program and homeless outreach and things like that. So we do a lot of helping folks get into housing. Often if we have somebody who's leaving a domestic violence situation and struggling to get housing, we might direct them to the Willows, but we would also be working with them through our agencies and things to figure out what we can do in-house to kind of support them in finding housing and get them someplace to stay quickly. And also help with other things like getting disability and getting housing vouchers and things like that to support more long-term independence. And then we also have the ability to kind of like wrap services around a family where maybe we see a parent who's experiencing abuse and really going through some heavy trauma, and we can help them find services for the kiddos in the house too, and some respite care and case management for the kids, and kind of get the schools involved and things like that. So we really try to pay attention to like all parts of what's going on with people's lives and kind of meet them where they're at and help them achieve their goals in the ways that they want to, which can be a pretty wide door on the different things we can do.
Yeah, that's excellent. I'm sure it can feel like intimidating, especially for the clients too, a lot of our things that we do in-house, we do empowerment based. We don't want to tell people what to do. We want to give them all of the information and be a support and walk alongside them. But when somebody's been controlling everything you do, it can be really hard to then say, okay, yeah, this is what I want, and this is what I want to. It can be very overwhelming sometimes. And some of the stuff you just mentioned kind of, made me think about, people who are, exhibiting that abusive behavior and seeking that power and control. When I first started doing this work, my assumption is anyone who was abusive was a bad person and could never change and never be helped. But a lot of the trainings that I've gone through as being a Willow employee has really shown me that that's not the case. In fact, some of those trainings show me some of my own abusive behavior. Because when we break it down and talk about abuse being something where we want to impose it's basically you want to impose your will on someone else. And you don't have to do anything physically violent to do that. I'm like, oh, well, I do that a lot. So had to really rethink things. So I love that you guys have so much available to both people going through that relationship. Because in the end, what we want is to teach everyone, even the people doing that abusive behavior, that they deserve to be in a healthy relationship, and what it means to be resilient and not need to seek that power and control. So that's really, really excellent. Megan, how about you guys?
So I think, working in crisis and the emergency department, I think the main thing that we do is, at least me personally, and I do see it with the social workers and the nurses that work in there, is that we're really trying to avoid them experiencing that institutional systemic abuse that people so often get into that cycle of, and then they don't trust people who are in a power differential relationship with them. And I mean, when we look at it, our relationship, there is a power differential unless we're in a peer support situation or something along those lines. And even then there's that power differential. So one thing that I really focus on when someone comes in is thinking about how to avoid allowing them to experience that systemic institutional abuse. And one thing I do right from the get-go is I get them water, I get them fed. If they don't have adequate clothing, put them in clothing, put them in scrubs. We make sure to make them feel like a human being. And because so often they are on the periphery of society and people aren't treating them that way, even treaters aren't treating them that way. And so I think we do a really great job, as good as we can do with what we've got in the ED, at providing that kind of care and those kinds of services, and doing it with empathy and compassion. And as we all know, Emily was talking about emotional regulation. The people that come into the ED under crisis oftentimes don't have that emotional regulation, and they're escalated and they're scared, and they're in this room that has no windows, quite honestly isn't a therapeutic environment, can feel like a jail cell, can feel very much like, they're being held against their will. And with involuntary, they, that is how they feel. They feel like they're being held against their will. They don't have any autonomy. They don't have any choice. And so I think what we do as a staff, even when they're involuntary, we try to give them as many choices as they can in that confined environment, and try to make it as therapeutic as possible for them, and really try to sit in their shoes and look at it from their perspective of that they're fearful and they're scared, and that this can seem punitive. But what we're really all trying to do as a team is find them those services, safety plan them to a safe environment, and get them the help that they need, and collaborate with, Burt Nash, collaborate with Heartland Radar, collaborate with the Willow, whoever we can get to, on board with us and get the help they need for them, and wrap those services. But as we know, that can always be a challenge. And oftentimes we have patients who come in and just don't trust the system because they've been abused by it.
Yeah, absolutely. I mean, I feel like there's a lot of times there's several agencies, working with one person or one family, all of us trying to piece together everything that person needs, because systemically it can be really difficult, with all the different limitations and barriers that we have, which in turn just means limitations and barriers for our clients. So, but yeah, I love that. The basically working with compassion and getting them what they need right off the bat, because we can't do anything else until we have those. I know that I forgot the word for it. I'm sure Susie
Safety
knows it.
needs, just like when they come in, I'll get them a warm blanket, I'll get
Yeah.
them food, I'll get them water. Those
Mhm.
basic things
Mhm.
are so meaningful to somebody.
Yeah.
They're like, oh my gosh, I just got a warm blanket, and how much this can calm someone.
Yeah,
Um,
for sure.
meeting those immediate needs when they come in,
Mhm.
and letting them know, I'm here to keep you safe. I'm here to give you water and keep you fed. And
Mhm.
when you're under my care, this is the kind of support and care I'm going to give to you.
Yeah, that's excellent. Thank you, Megan. Well, so some of the stuff we want to talk about, also is, like I said, the cost of prevention versus crisis intervention. So when we're talking about prevention work, we're talking about doing that education, or working with people and families before those things are happening, even if they've gone through trauma, even if they have their own cycles of violence. Maybe it's a situation where we're working with them for something else, but this stuff comes up. We're able to do that education. We're able to form a good relationship, a trusting relationship with them, where they feel safe to talk to us, safe to disclose, safe to come to us when something maybe does happen. So um, w- here at the Willow, there was a study done through KU that helped us to kind of figure out what those costs look like in our community. And so they are some big numbers that they've collected. So when we are talking about emergency services, it said cost per individual is $57,026. And then Willow Shelter Services, our cost per individual is $3,955. And so in the community, especially, I think one of the biggest numbers that we're seeing is like for the Kansas Department of Children and Families, their cost for housing and food for individuals is, I'm not even gonna say the whole number. It's a little over 6 million. But for the Willow, for us to do like our shelter services and stuff, it's about $641,000 that we're doing. And so that kind of gives us an idea of what those numbers look like. And again, it's not about about the money specifically, what it's costing, people in general, maybe as the community. But again, these things are taking a toll on our community, all sorts of different ways. That impact is sometimes monetary, and sometimes it's not, or it's like kind of a trickle down monetary type of thing. So my question for you all is, when you're working with a client who's currently experiencing domestic violence, or has experienced it in the past, what is the cost to them that you guys are seeing? And then how do you see domestic violence affecting the rest of their finances? Emily, you want to go?
Sure. So I would say, gosh, that's such a complicated question. Because so many of our folks that are experiencing domestic violence have had a lot of opportunity cost because of it, whether it is their partner not wanting them to work because they feel threatened by an environment or a person at their work, or them leaving school as a result of their relationships, or even just struggling with emotional regulation enough to be able to hold down a job or to attend school or to even know how to access those things. Often we have folks who come in as young adults for services, who really have had to kind of fend for themselves throughout their childhood and maybe could have used some intervention for their safety and things like that, but they never really learned those basic life skills as a result. And so the skill set that they have is one for surviving, right? And for surviving constant crisis. And so it's a lot of work where we are helping them kind of like unlearn things and learn new things, right? Like we often have adults that come into our program who don't have the basic life skills, like how to manage like regularly brushing their teeth and doing their dishes, and what you do to get your car insured and all of those things, because no one's ever taught them. And so we can, within our therapy, we can kind of like start working on targeting those types of things and building patterns and building behaviors. But then there's also like the other costs that just come from having that chronic trauma and the things that it does to someone's psyche and nervous system, where often the folks that we work with have had like multiple suicide attempts and have been repeatedly hospitalized. And there's a definite line that you can draw between like chronic childhood abuse and neglect straight into like adult mental health crisis services, where many of those folks, if there had been earlier intervention with the families and different things happening younger, maybe some of that could have been prevented. From our end, we try to kind of interrupt the pattern of repeated crisis and hospitalization by really reinforcing help seeking at like lower levels of acuity, and reaching out and giving tons and tons of support to kind of start breaking some of those patterns of crisis behaviors, which ends up being a pretty massive cost reduction, particularly if we can take someone who's like regularly going to the ER because of all of the chaos in their life for one reason or another, and we're able to kind of stabilize them with community-based services, right? We have a sliding fee scale where folks that are struggling with housing might get services from us for free, and other folks who are lower income would be paying around $15 an hour for therapy. And if you compare that to like what their bill would look like if they end up in the emergency room in a mental health crisis or in a hospital, it becomes a really big cost difference to the county. The other end of that is that when they do go into the hospital or into the emergency room, you're interrupting their life, right? So maybe they did manage to get a part-time job, or they're caring for their child or something like that. And then they have a mental health crisis, and all of a sudden their kid is back in DCF custody because there's no adult in the house. And, they've lost that job because they just started. And all of these like things that happen as a consequence of them needing that higher level of intervention, that just make that like ongoing stabilization process more difficult. So it really is, if we can get in there and get them really locked in with lots of support in the community, we can save a lot of those costs down the road later on. Yeah.
Excellent. I love all of that. We at the Willow, we do a healthy relationships and parenting support group class on Mondays, and Tony Deathridge is a therapist who leads that group for us. And I remember one time in a group, she was talking about how our brains function. So when we were little, if we were constantly living in survival mode, and not being able to develop our emotional and thinking brains, part of our brains, then survival mode feels comfortable. And so as we get older, it feels better to be in that survival mode than to be when things are calm, And so I used to do group in the jail, and we would talk about that sort of thing, because it feels like, well, I know this is bad, but I keep doing it, or people are looking at me like, well, why don't you just stop? Why do you keep going and, quote unquote, messing up and things like that? And it's because that is more comfortable for us. That chaos feels more comfortable. If I'm in a healthy relationship, that feels boring. It might even feel kind of icky, because that has not been the norm for me. And so I would rather live in that survival mode, because at least I know it, and so I think that's really great what you're talking about, just the more support they have early on, and just disrupting that sort of thing, and introducing the other is a really great way to do some prevention work for sure. So thank you. Megan?
I think one thing that I hear a lot about, especially now, is economic insecurity within the homes and home environments. I think, we need to kind of look at, is it viable? What are the costs in our society right now with inflation, with increases in daycare, being able to work outside the home and actually support our families? So what I hear a lot of is, there's this absolute economic insecurity. And I think that, there's a lot of costs, especially to, domestic violence and the correlation with women that I see that don't feel like they can leave. And they can't leave that situation right now. And so I think societally, we aren't setting people up to be able to escape or flee violence. When a single person can barely make it anymore, and on their income, one income alone, most people have to work 2 or 3 jobs just to get by. And so I think we're setting up a huge cost to our society, people not being able to leave. And I think another thing that we need to look at is within our own organizations, is that we tend to ignore and turn a blind eye to what does it cost our organizations when our own employees are experiencing domestic violence. And we don't want to talk about that. We don't want to sit in a room as an executive director and look at that employee across the way and go, I need to ask you a really difficult question. Are you experiencing intimate partner violence? But I think we all need to be doing that, because if we, the treaters, are experiencing it ourselves, how are we going to be helpful to others in our own lives? And so I think as organizations, we need to look intrinsically, we need to look within, we need to start healing workers and the treaters that are in our organizations and stop ignoring that maybe they are experiencing domestic violence. I think that's really important. And I think that would lower the costs and we'd become more effective at what we're doing. Not that we're not, but I think there's just, it's a really difficult answer to that question. And Emily really nailed it with like, you know, the physical costs, the medical costs, the societal costs, the, you know, and so I think we just need to we need to start in our organizations and look at, you know, what it costs us as employees and treaters and providers and kind of work our way out from there.
Thanks, Megan. I really appreciate that. That is spot on for sure. We often, as we all say as treaters, like can't pour from an empty cup, right? How are you going to help someone through that situation if you're experiencing it? So having agencies and organizations that treat their employees the same as they would treat a client with compassion and understanding and grace is definitely really important. So thank you for that.
Yeah, and I just think it helps to decrease the overall costs of this to society, but it's such a multi-layered, multifaceted answer. It's complex.
I'm like, we could go on for days.
On and on. Yeah.
Yeah. Susie, how about you?
Yeah, thank you. I will just add to the complexity of this question because I agree with what everyone said. It's completely complex. And then if you take the idea of economic insecurity and instability and add infant care on top of that, I mean, infant care is over $1,000 a month. So just the childcare in and of itself is a crisis in our community and our state. So to add any type of barrier or weight on top of the barrier and weight of childcare be really, really daunting for any family. I also think of prevention as a multi-generational approach. And so as I'm working with an 18-month-old kid, I might not see any of the things we're working on bloom through that child yet, but with working with that parent-child relationship, building protective factors and helping caregivers, as we've talked about, unlearn and relearn different ways of emotional regulation. What does it mean to be in a healthy relationship? How can I start modeling consent for my 18-month-old? What does that look like? So just building the foundations for those so early that we're building new generations of kids who are so used to talking about healthy relationships. When Adrianne comes to your school to talk about it, they're like, I've got this. My caregivers have modeled this for years. So working with that long-term multi-generational approach, I think is huge with decreasing those costs. And then the other thing with costs, I think we also have to bring early intervention, special education into this conversation, because when we think about how trauma impacts a developing brain, we know that there are skills within development that for all sorts of reasons are most likely not met in the time frame that we would hope that they would be. So there are costs to our school systems, to our community for services for those children, building skills, and for caregivers building capacity to meet their children's skills and needs. So that's another aspect that I have no doubt is intersected with domestic violence in multiple different ways.
That really leads really perfectly into our next question, which is
unplanned, but you're welcome.
Thank you. So our next question is, what is the cost to the community as far as the work that you're doing with your organization? I kind of think along the lines of like, what, like at the Willow, like the money that we spend on our clients to help them trying to put things back together, trying to get on their feet, the money we funnel through is, of course, again, a lot into housing, a lot into helping with bills, a lot into helping with that missed rent because, they were unable to work. I also think of too, like, I've had so many clients in the past that, childcare is so expensive. And so if I want to get help from DCF, I can't make too much money though. And so I have to be really, really mindful about the work that I'm doing. Because if I make too much, then I can't get that help. But even if I make more, it's usually not enough to actually cover the cost of that childcare. And so it's almost like punitive to be like, you want, to get this help, you can't make more than this much. So it keeps you stuck. I've got the help with childcare now, but I'm not allowed to make more than this. And so I'm just really still moving paycheck to paycheck. And so since you were kind of already touching on it, Susie, and you kind of already did, is there anything else you'd want to add to that conversation around the cost of the community, like as far as like what your organization does and the things that you guys are doing and the cost within your agency?
Yeah, I think what I would add to the cost of the community is community care and caregiver connections to decrease some stigma and shame that comes along with being a survivor of a domestic violence relationship and situation. Being a caregiver who's navigating parenting and repairing that relationship comes with a lot of self-doubt and a lot of weight, and having some peer support and a community to really wrap around you and support in that process, whether that's a couple agencies or whether that's a group of people who have been in similar situations or a friend from high school, whatever it is. I think really building as organizations, building up opportunities for community care and peer support, and really relying on that as a very valid way to support and treat families in our community.
Excellent. Thank you so much. I think domestic violence and human trafficking, it thrives in disconnection. And so when we're able to connect, even with just one person, let alone having multiple support systems, like that is exactly what an abusive person doesn't want, because they know that will help them, to remember that, they don't deserve that and to not live in that shame. So that's excellent. Thank you. How about you, Megan? What do you guys think? LMH, kind of what is the cost to the community and to LMH with domestic violence?
Well, it's kind of difficult to speak to that because I know, we talk about like ED costs and just the cost to the individual and then the cost to the hospital itself. And then it just kind of trickles out from there. The one thing that I think I see a lot of, and I'm not going to go on a soapbox about this, is that people that are being admitted in may look like they are the primary abuser. And so they're being called the abuser. You're the primary abuser. You're the one who's going to go to jail. You're the one who's going to suffer the consequences. When, as we know, there's that thing called reactive abuse. And so, the criminal justice system is probably one of my bigger soapboxes about criminalizing people who have been victims of abuse, but they're deemed the primary abuser. And so sometimes when people do come into the ED, they're there because of law enforcement. And while they might be demonstrating abusive behaviors, getting down to the reason as to why. And I think we're trying to do that in our community. We're trying to have the crisis intervention team and people kind of intervening. But I think at the end of the day, we have a lot of work to do in the criminal justice system. So I do see a lot of interaction with that. And so I think that's a major cost. But as to the hospital itself, I mean, that's just going to happen. That's right now, they're one touchstone, they're one place to go when they're in crisis. And so, that's what we've got for the community as of right now until the treatment and recovery center opens. But we also do have Burt Nash. But in terms of like getting people in there with the criminal justice, we do see a lot of people dropped off by law enforcement. And so I think there is a cost to that, especially mentally for the individual that's being dropped off by law enforcement. So.
Yeah, absolutely. Thank you, Megan. Emily, how about you guys?
Well, I feel like there's so many things that have already been touched on that we kind of have a little bit of our fingers in a lot of different areas of service in town.
You really do.
Yeah.
You
So I know that a lot of the county's effort and our effort in LMH's in the last couple of years has really been beefing up our crisis response, getting the treatment and recovery center open and all of those things. And that there's kind of some upfront costs to the community as we get those started, but long term, it'll reduce cost at LMH and at the jail and for law enforcement. You know, if we can prevent law enforcement or EMS from having to go out and intervene in something because we already have somebody engaged in services and they have a plan for what to do if things escalate and we're addressing the needs, then we can reserve some of those emergency services for as more of a last resort than they tend to be at times. You also said a minute ago something about abuse thriving in the shadows or something like that. It was very eloquent the way you
It's
put it.
very in disconnection.
Yeah,
It thrives in disconnection because that's
right.
isolation, what they want. So
That made me think about how many services that we have that are targeting homeless folks, and homeless women, and gender diverse folks who are homeless in particular are targeted very heavily for sexual abuse and for domestic violence, intimate partner violence, often have that pattern in relationships of really strong control where they don't feel they might have a partner that's kind of a protector, and they don't necessarily feel comfortable leaving that relationship as they're unhoused because that's kind of the one source of safety that they have, from other people that might victimize them. And there's so much within folks that are chronically unhoused. There's so much vulnerability and disconnection from other parts of our community, and a lot of judgment, that really prevent those folks from getting the help that they need, because when they do sometimes reach out, they're seen as like that being the primary thing that we see rather than the domestic violence, rather than the mental illness, the addiction, all these other bits, that really need to be addressed. And I think a lot of our services have really pivoted in the time that I've been here towards more of a housing first model, where we're really recognizing that need among folks who've had chronic trauma. And I think homelessness in itself is a trauma for nearly everyone who experiences it. But being able to get them in a place where they can physically have that sense of safety, that's kind of like really a first step, right? Before we can do anything to address mental illness or get them working or get them, coping with substance abuse. First, they need, a door of their own that they can lock behind them. And once we can kind of start getting those things wrapped around them and lots of other supports, then we end up saving the community a lot of money in all sorts of different ways, whether it's from a sanitation point of cleaning up camps, whether it's from, reducing the cost of law enforcement intervening when things happen in public areas, even just concerns that we have about folks hanging out downtown and things like that. That's a cost to our community, in a way, right, for a certain population. So if we're worried about those things, then we really need to figure out how to kind of wrap around these folks and meet them where they're at and support them in getting more stable so that they can be, so that they can contribute to their full capacity, and we can kind of get to know them and have them be a part of the community more. Yeah.
I appreciate that. Yes, I think housing first, and I mean, all of us have been doing a lot of this work for years, and just how difficult it is for someone to meet all of the requirements to get housing. Expected to do all of that while you don't even have your basic needs met most of the time, is really difficult. And so, kind of like Megan was talking about earlier, just someone coming into the ED and just getting them that water, getting them the clothes that they need, a warm blanket, like they need we need our basic needs met before we can move forward. So I really, yes, housing first is definitely, I think, something that may look like a big cost, but in the end is really going to keep our costs down, because people will be set up to succeed more than what they are right now. So I appreciate that. Well, we'll wrap up with one last question, which I feel like we'll probably all say the same thing, but just looking at this as a public health crisis, how do we improve our process, or our processes to help survivors and to reduce the cost to public health? Megan, you want to start?
I think my biggest thing is to reduce turnover in our organizations so that our patients have continuity of care, and that their care doesn't get fragmented, where one day they have one counselor and then 2 weeks later they have another. Maybe there's this peer support person that they built this trusting relationship with, and then 2 months later that person is no longer working for that organization. So what I would like to see is us, the recidivism of like keeping people within our organizations and keeping people, our employees, happy and healthy and whole, and focusing there. So we aren't providing fragmented care to patients, because as we know, even somebody who has like a more high functioning status, when we get fragmented care, it's frustrating and it's hurtful and it's harmful and it's abusive. And so we need to really focus in, I think, on decreasing that, and really keeping people within our organizations and taking care of them. I think that has to be our primary before we can take care of other people.
All right, excellent. I appreciate that. Thank you. Susie?
I actually think this is the hardest question of all of them, because there are so many things. If we sit and really dream about what could be, it's really a very different picture than what's happening now. I would really advocate for more multi-generational services, for collaboration amongst agencies, that if there's a baby, if there's a grandparent involved, connecting to all of those other resources so that we're outreaching and wrapping our arms around that family from multiple different ways. I think just as we have a childcare crisis that is of utmost importance for us to work on, as well as therapy services for people who are trained in infant and early childhood mental health and that parent-child relationship. We have some wonderful therapists in town. We just simply need more. So more that can really work in that parent-child relationship capacity. And again, putting a plug out there for connection. I'm really sitting with what you had said, Adrianne, because disconnection is what makes it thrive. And so if we can just promote connection in any way that can build capacity and strength and vulnerability and power for that client to build their connection in a way that's meaningful for them, I think we'll see a lot of really wonderful change happen.
Yeah, excellent. Susie, remind me, what class are we in with you guys? What's the name?
It's called responsive caregiving.
So yeah, my husband and I are in Susie's responsive caregiving class, which I always forget the name, but when I'm explaining it to people, I tell them it's the class where basically when your toddler triggers you, you learn how to not lose it on them. So,
Right.
So very, very helpful. And again, creating connection with other families and with
Yes.
the Children Community Center to help us figure out how to break our cycles. And
Yep.
some of the stuff you were saying earlier, just being able to kind of reparent yourself as you're parenting your child is a super awesome thing to go through. I think I personally really love it. And so I love that
Yes.
resources that you guys are providing the community.
Yeah, thank you. So we offer that class quarterly. So if anyone watching this, or if you know any clients who would be interested, we do have it geared towards 0 to 5. But any caregiver that would like to participate, I would welcome them reaching out to us. We will probably host another one again in January. Will be the next time we start that session. And don't we all need that, right? If we all could say that responsive caregivers, not only to our children, but to ourselves, to our partners, to our community, what a difference that would make. So
yeah, absolutely. Thank you, Susie.
Yeah, thanks.
And Emily, how you want to wrap things up for Bert Nash for us?
Sure. So, I mean, I guess the biggest thing that we're working on right now, I think, as far as like thinking of mental health and domestic violence as a public health crisis, is really improving our access to care. We're reworking the way that we're doing our admissions process to make it much more crisis and trauma informed for folks, and much quicker to get people into the services that they need to be in. So that should do quite a bit to get down wait times to actually enter services. But then across our programs, working on expanding services to meet the need, training staff, and figuring out how to get folks the care that they need when they need it, right? Because it is not helpful when someone is waiting for an extended period to try to get in for help, right? When they're looking for it. Again, I'll say that, housing, affordable housing is a massive need in our community right now, and it seems to be more and more. And I think that when you're talking about, as Megan was saying earlier, helping someone exit a domestic violence situation, if you don't have anywhere to help them get to, and they're financially dependent upon the person who's harming them, it's a really tough sell. And so the community is going to keep incurring those costs related to that until we can figure out how to get them out of there and stable on their own and things like that. Susie's mentioned the cost of childcare is a big barrier a couple times. We see that all the time for our clients where they struggle to engage in the intensity of services that we'd like them to because they don't have childcare. And so they can't say come to group therapy every morning because there's no one to watch their kiddo. And so figuring out some of those problems. But I do think that Lawrence as a community is an incredibly unique and special place. And that our ability to kind of like have a sense of community and connect with one another is totally one of the strengths of being part of this town, where folks really do want to kind of act as a village in a way and wrap around one another. So I think that the more that we can focus on having ways for people to come together and get to know each other and get to know their neighbors and really develop those community bonds that are so hard to build in this crazy modern world. So continuing to kind of like foster that and then connect to each other when we're all helping the same people from different directions and making sure we're all talking to each other and following up with one another and all of that. So there's lots of big ways and little ways to kind of work on it.
Yeah. I just mentioned that I just realized all four of us are townies, so that's probably we'll just start this going. We'll get that conversation going, and we love our town, right? Great. My moderator here, Maggie, do we have any questions on the chat? I know we're a little over our time. Or
Hey,
Will.
it's Will. Yeah, I think we've answered everybody's questions. We're all good.
Great. Excellent. All right. Well, thank you guys so much. I appreciate you guys being a part of this. All the work that you're doing, all of the work that your agencies and organizations are doing. I know we're all trying to get better every day, and hopefully we'll all stay connected and keep on working on the best way to create these processes to help with the cost to public health. So thank you all for being here. We appreciate it so much.
Thank you, Adrienne. Thanks, Will. Thanks, Maggie.